and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Frederick Foley, who will be talking to us today about enhancing sexual wellness. After a presentation from him, we'll open it up to your questions and comments. So now I'm delighted to introduce you to Dr. Foley by reading his bio. Dr. Foley received his Ph.D. in clinical psychology from Fordham University. He's a professor of psychology at Forfuk Graduate School of Psychology of Yeshiva University, Bronx, New York, and director of neuropsychology at Holy Name Medical Center's MS Center. He has published over 150 scientific articles, book chapters, and abstracts, and his translational research on depression and immune desegregation in MS won the Dorfman Award for the Academy of Psychosomatic Medicine. He has served on the Medical Advisory Committee of the National MS Society and served as president of the Consortium of Multiple Sclerosis Centers, the CMSC. The CMSC dedicated an award in his name, the Fred Foley Award, which is given annually to a person who has contributed greatly to advances in treatment for psychiatric disorders in multiple sclerosis. Dr. Foley also received a Giant of MS Award from the CMSC in 2002 for all of his work. He has been the recipient of numerous research and educational grants from the federal government and private foundations, and has served on many scientific committees. And he's also been an advisor or consultant for numerous for-profit and nonprofit organizations on MS-related topics. Dr. Foley, thank you so much for being here today. I'm going to turn this over to you so you can educate all of us.
Thank you very much, Deborah, and welcome everybody. I'm honored to be here to talk to you tonight about how to enhance sexual function in MS. So, but before we understand what problems, occur in MS, it's good to put this in perspective and look at what happens in the general population. When we look at just the general adult population, 52% of men kind of reported at least occasional sexual dysfunction. And in a large study that looked at adults from 18 to 65, the National Health and Social Life Survey, 43% of adult women and 31% of adult men in the United States reported at least occasional sexual dysfunction. So it's important to put that in perspective, that this is very common in the general population of adults in the United States and around the world. So, but we're going to talk about what's different about MS, and we're going to talk about, what you can do about it. Okay, so in terms of how often do sexual problems occur in MS, I'm just going to skip. We did a study of 9,000 persons with MS in the United States and found that 68% of them reported at least one significant sexual dysfunction that interfered always or almost always with their sex lives. So you've seen, I've mentioned the stats in the general adult population. You can see in MS, it occurs more frequently. I've gone around the country training MS physicians and general neurologists about how to talk to their patients about this, because it's really just as they may ask you about your walking or your bladder, they should also be asking you about your sex life. And they should be asking you about it because there's a lot that can be done about it. And we're going to talk about that. When we first started studying sexual dysfunction, we kind of developed the idea that there are three different kinds in MS: primary sexual dysfunction, secondary sexual dysfunction, and tertiary sexual dysfunction. Primary sexual dysfunction we defined as a result of MS-related changes in the central nervous system that directly impair sexual feelings or response. For example, if you have a lesion in the sacral area of your spine, there's a very high probability you will have genital numbness. That's an example of a primary sexual dysfunction. where the lesion itself is directly impacting the function. Secondary sexual dysfunction occurs as MS-related physical changes or symptomatic treatments that indirectly affect sexual feelings or response. For example, some antidepressants cause a lot of sexual dysfunction. So that would be an example of a secondary. You get depressed, you get prescribed an antidepressant. Now, some antidepressants cause little or no sexual dysfunction, but some do. So that's one thing that you can do. If you're going to take an antidepressant, tell your doctor, hey, can you give me one that's not going to impact my sexual functioning very much? So, and some other medicines can cause it as well. A tertiary sexual dysfunction refers to the psychological, social, and cultural issues that interfere with sexual feelings or response. For example, like body image concerns can sometimes interfere with sexual pleasure or sexual functioning. That would be an example of a tertiary sexual dysfunction. In our 9,000 patient study, we used the Multiple Sclerosis Intimacy and Sexuality Questionnaire, which we developed in our lab. And as I said, during the criterion for reporting a significant sexual problem in the study was at least one symptom had to interfere always or almost always. And so, yeah, it was 67.2% of MS persons with MS endorsed significant sexual dysfunction over the previous 6 months. So in terms of, I'm going to move to the top 5 symptoms that men complained of. Difficulty getting or keeping a satisfactory erection. That's really the #1 complaint of men in every study on sexual dysfunction, whether it's in MS or the general population. Second was loss of confidence in men about their sexuality due to MS. The third most frequent, less intense or pleasurable orgasms, taking too long to climax, and less feeling or numbness in the genitals. The top 5 symptoms for women were 1 and 2 were about having problems with orgasm. The third was a lack of sexual desire, inadequate vaginal wetness or lubrication, or less feeling or numbness in the genitals. We compared men and women on how severe their sexual dysfunction. They were virtually identical in terms of the frequency and severity of it between men and women. The symptoms were just different. So we've concluded from this research that sexual dysfunction is highly prevalent in both men and women with MS, that the severity of it is almost identical for men and women, and that this really is a major area that healthcare providers need to address in terms of helping persons with MS improve the quality of their lives. Okay, so some examples of primary sexual dysfunction include sometimes MS can directly impair libido or sex drive, altered genital sensations, just as you can have sensory paresthesias in your feet or in your hands, you can also get them in your genitals, depending on where the lesions are located. Decreased frequency or intensity of orgasms, erectile dysfunction, decreased vaginal lubrication and clitoral engorgement, and decreased vaginal muscle tone are all examples of what could be a primary sexual dysfunction. Secondary dysfunctions include bladder or bowel dysfunction, fatigue, other sensory paresthesias, but not in the genitals, spasticity, decreased muscle tone, tremor, or pain are all MS symptoms that could make you not want to have sex, when you're extremely fatigued. And I just want to give you a couple of clinical case examples of persons with MS and their partners that I've treated over the years. I remember one couple came in and said, "Dr. Foley, we haven't had sex in over a year." And I said, "Okay, what's the problem?" They were a couple in their early 30s. They both worked full time. She had MS, and they had a couple of young kids at home. So she said, by the end of the day, I am so wiped out that the last thing in the world I feel like doing is having sex, after we get the kids in bed. So I asked her, some people, when it comes to having sex, can be evening people, and some people can be early morning people. I was wondering if you could become an early morning couple when you still have energy. And they looked at me horrified and said, no, no, no. My list of things to do uh, is there. I'll be thinking about going to work. We'll be thinking about taking care of the kids. So we can't become morning people. And I want to tell you how they solve the problem. What I tell everybody is I give them educational materials about sexuality and MS, and I encourage them to just talk about it openly and non-defensively and lovingly with each other, and try to brainstorm and see if you come up with any ideas. And I said that to this couple. I said, I want to see you back in a month and see what you came up with. And they came back a month later smiling. So they both realized that uh, they didn't work that far from their home. And so on Fridays, they both negotiated extended lunch periods with their respective companies. And the kids were in school, house was quiet, and they would come home at lunchtime, and she still had energy at that point in the day. And, so they came up with their own solution. And they said, they weren't having sex every Friday, but they still cherished the time together, in the middle of the day on Fridays. And they said, I know MS is going to throw us curveballs down the road, but now, just as we solve this problem, I'm sure we'll solve the other problems that MS puts in our way. So the most important thing of our research found that educating people about sexuality and MS and giving them examples of solutions leads to significantly improved satisfaction and function. And we found this out in several studies we collected data on. So I want you to remember that. The National MS Society has materials on sexuality and MS. So there is a lot of information out there on it. That information, will give you the knowledge you need to kind of be able to do something about much of it and solve the problems. Okay. Um, uh, Again, I've treated many people who claim that, well, I'm afraid my bladder's going to let loose when I was having sex. And this seems to happen much more frequently in women than it does in men. So what I did in cases like that, I said, well, you can talk to your doctor about intermittent catheterization or adjusting your bladder med schedules, or kind of emptying, before activity. And, I would always bring the partners in the room, and I would ask the partners, would you care if there was a bladder accident in bed? And almost every single partner said, no, I just want to have sex. So I could care less, if the bed gets wet. So, um, so again, but they were afraid to discuss it with their partners. So, just another example, and cognitive impairments can interfere with sex. I had one couple who came in, and, she had a severe attention and concentration deficit. And people like to be touched differently. The beginning of a sexual encounter, in the middle of a sexual encounter, and towards the end of a sexual encounter. So there's a sequence of what feels pleasant to you at each point in the interchange. And she would kind of, having the attention deficit, she would be kind of in the middle of a sexual encounter with her husband. And all of a sudden she would like lose her place, so to speak, cognitively. And the way he was touching her didn't feel good anymore. So once we understood what was driving the issue, we I just instructed the couple to, hey, if she loses her place, go back to square one and start over. Then and touch her in the way she likes in the beginning. And I also they had the TV on in the bedroom a lot. That's a curse for a happy sex life frequently. So I had them kind of minimize distractions, kind of taught her strategies for how to get back on track, improve the communication between the two of them, and they resumed a very healthy and happy sex life. So it really didn't take that much. Okay, so these are just some examples I've learned over the years. I have this particular slide up now because frequently patients do need some technical advice. Like, for example, how do you have sex with a catheter? Or how do you have sex in a wheelchair? I've had a number of couples ask me, how can we have sex in my wheelchair? And so sometimes they just need technical advice on how to deal with appliances or, um, equipment that they have and need to use during sexual activities. I had one man came in who had an indwelling Foley catheter at the time for a period of time. No relation to this Foley over here, but uh, and he said, "Well, how can I have sex? I have this catheter hanging out of the end of my penis." I said to him, "Okay, go home, shave your penis, you know, uh, take the catheter, fold it down along the length of your penis, put a condom on, and you're good to go. And if you need to, put a little paper tape around the base to keep it in place and keep the catheter from moving around too much so you don't get irritated." Likewise with women, we advise them how to fold the catheter up and away from uh, their genitals so that it won't move too much and irritate them. So sometimes technical advice is needed on how to position yourselves for sex when MS changes your strength or your body in certain ways. Um, okay, and that's what we give our patients. We give them the technical advice that they need to be successful. I have this picture up here because 28% of women with MS in our study had significant body image concerns that they said interfered almost always with their sexual pleasure. And women in the Western civilization are more prone to body image problems than men are. And that's why I have this slide up here. And I want to show you some slides I just took out of a fashion magazine. So women in Western societies are frequently depicted as anorexic. The typical American fashion model is 5 foot 11 inches tall and weighs 118 pounds. The typical American woman is 5 foot 4.5 or 5 foot 5 inches and weighs 150 pounds. So, the way women are depicted in the press and in our civilization kind of drives them to think that their bodies aren't perfect just the way they are. And so we have to teach them to kind of learn to re-love their bodies and, exactly the way they are. And so we give them some brief counseling that helps them do that. I have this picture, up here because the sexual ideal for women changes throughout time. And, in the late 19th century, kind of very round women were considered beautiful, and that was the ideal. Okay. Now, I have this slide up here because the American Academy of Aesthetic Plastic Surgery reported that just before the pandemic, over 10 million women in 1 year had plastic surgery just for aesthetic reasons, not for medical reasons. That's a lot of heavy pressure that women are under. If you think about it, that they need to change their bodies in order to feel okay, about themselves. And that's what I mean by a tertiary sexual dysfunction. The culture kind of seeps into you and causes you to make, negative judgments about yourself. For men, erectile dysfunction was their big concern, maintaining an erection, and losing sexual confidence was another big one. So, and there's many things we can do about. Basically today, the technology exists to give any man an erection, no matter what illness they have or what problems they have. As long as they have a penis, we can make it go up for you. So I have this slide up because it reminds me of a couple that I once treated. And they came in to see me and said, our sex life kind of died. And I asked them, when did that start happening? And it happened about 6 months prior. The man had MS and he transitioned from a walker into a wheelchair. They used to have a very sexy relationship, a lot of double entendres with sexual hints, kind of touching each other, flirting with each other. And he realized that after he went into a wheelchair, he felt like a disabled person. And in his head, being disabled meant he couldn't be a sexual being anymore. And he said, it just kind of snuck up on me. I didn't even realize what was happening. I said, you go home and start being sexy with your wife again. By the way, she called me personally to thank me. So sometimes these ideas get into us about, why can't someone with a disability be sexy, and have a good sex life? MS changes relationships and changes roles in the home. So maybe the person with MS has to work fewer hours or not work at all, or needs help, around the house doing things that they used to be able to do. So sometimes these changes in roles can kind of make oneself uncomfortable, in terms of your sexual role. So tertiary sexual dysfunctions, as I mentioned, include changes in self-image or body image. Demoralization or grief, can also cause sexual dysfunction or a clinical depression. Performance anxiety we found was very common in men with MS and interfered. And role conflict, and as I've mentioned, these internalized cultural values that create sexuality inhibiting expectations and judgments. So this is the most important message I want to give to you, is that it's important that you talk about it. It's important that you talk about it with your healthcare team. Studies of physicians have found that if the patient brings it up, they will do their best to address that symptom for them or refer them to someone who can. We did a survey of physicians asking them why they didn't talk about it. And the biggest reason that they offered us was that, well, I don't want to make any patients uncomfortable. If they kind of ask me about it, I will do my best to help them. So everyone kind of listening tonight, if you have any sexual concerns, please bring it up with your healthcare team. We found that they really will try to help you with it, but just frequently don't want to be what they perceive as intrusive and ask about something like that. So get the help for it, because the help is out there. The neurology of the sexual response is very complex. There are areas throughout the brain that regulate different aspects of the sexual response and sexual satisfaction. So, because it's so complex and because lesions in different area of the spine, lesions in different area of the brain can cause a primary dysfunction or secondary or tertiary ones, we realize that that's probably why so many people with MS, have some difficulty with this topic. When we rehab sexual function, we do that assessment of primary, secondary, and tertiary factors. And the most important factor is education and empowerment. We transition the person to become an active problem solver in this area. Most people come up with their own solutions, like that couple who had the fatigue and hadn't had sex in over a year. And so I found that I can make suggestions, but I first encourage people to educate themselves about it. I supply them with materials and on it that they can then openly talk about and discuss with each other and then brainstorm. And, as I mentioned before, in several studies we've done, we found that to be highly effective. Sometimes medical symptoms need to be managed better too. So, if your spasticity is interfering, well, maybe, there's something you can do about a symptom, whether it's fatigue management or getting better handle on bladder control or managing your spasticity better. So good symptom management that's on symptoms that are interfering is also important. And communication skills training, we teach people how to talk about sex. Couples tell me, I don't know how to talk about sex. And so we guide them on how they can do it in kind of a confident way, in an open way, and in an accepting way with each other. So I have this slide up here because clinical trials of improving sexual health have really been geared primarily towards men. And women have more dimensions to their sexual selves than men frequently do. I mean, if you give a man erection, the sun will come out, the stock market will go up, and people will be cheering in the streets. There were trials done of sildenafil citrate, which is the kind of which is Viagra, and in women with MS. And even though the mechanisms biologically are identical between men and women, in men, erectile tissue fills with blood. In women, erectile tissue fills with blood. And so they would have more clitoral engorgement. I mean, the drug was working in that way, but they weren't reporting any more frequency of sex or sexual satisfaction. And this made me realize that clinical trials have to be designed for women, and adopting a male clinical trial that just is going to give them an erection, and it's going to be one drug or one thing, one intervention. So there are now many FDA-approved oral meds that can, for managing sexual dysfunction. And so it's, that they frequently work well in my patients with MS. Some of my patients with MS use what's depicted here, which is a vacuum pump. You place a tube over the penis, and you pump the air out, and the pressure differential between the inside of the penis and the tube fills the penis with blood. Patients of mine that don't want to take any more meds, frequently like this and report good satisfaction with it. Then a band is placed around the base of the penis after the penis is pumped up to keep the blood in the penis for sexual activity. Sometimes the oral meds for erectile dysfunction, don't work well. And so, because those meds, the phosphodiesterase type 5 inhibitors, like sildenafil and tadalafil and others, they work by helping you just maintain an erection. You have to have the biological capability to initiate the erection. And if you lose that, they won't work. So there's what we call intracavernosal injection therapy. Well, now most men that I talk to about injecting their penises kind of blanch at the thought of it. But it comes with an auto injector. You can't even see the needle. It just feels like the flick of a rubber band. It's not very painful. So, and one of my patients, after trying it, and I sent him to a urologist, and the urologist titrated the dose for him in the office, because you can't have too much of a good thing. You can, if you're having an erection that lasts more than 4 hours, all the oxygen in the penis has been used up and the tissue starts dying. So you don't want to have too long of an erection, either. So that's why the urologist makes sure they give you the right dose of this so that you can enjoy the erection. So this patient came back to me after I referred him, and he said to me, Dr. Foley, that injection therapy is the best thing ever. It doesn't matter whether I'm awake, whether I'm asleep, whether I'm alive, whether I'm dead. It's going to go up and stay up. So there's very high satisfaction with that. There are also intraurethral suppositories. I don't know any man that likes them. There's some topical medications you can apply. And of course, just as for women, there are sexual aids, vibrators, and other kinds of sexual devices and toys that can enhance that sexual experience. And above all else, education is so important. In terms of managing sexual dysfunction in women, okay, first, a little hardware knowledge, is important to know that the vulva is a distinct organ separate from the vagina. The vulva is where the clitoris is. That's where pleasure comes from. And also, some women have told me they don't like their labia. I try to tell them, well, unless there's a medical problem, all labia are normal. They're like snowflakes. They're just all different. You just need to kind of accept and appreciate the labia you were given. Um, so in terms of understanding arousal in women, 90% of the clitoris is inside, and inside the labia. Women, when I tell them this, they're frequently surprised, have almost as much erectile tissue as men do. It's just kind of most of it is inside the labia. And so this erectile tissue needs proper arousal, prior to any kind of penetration, if there's going to be penetration, during the sex act. And otherwise, there could be vaginal pain, and that pain is mostly due to pain in the vestibular glands, in the genitals. So here you can see the structure of the clitoris, and you can see all this pink area is all erectile tissue. And the glans clitoris is just this tiny little button, but there's much more, almost as much as erectile tissue in men. Orgasm comes from the clitoris, not the vagina. Women tell me I have vaginal orgasms, clitoral orgasms, anal orgasms. They all come from the clitoris. It just, in different sexual acts, you're pressuring it differently or stimulating it differently, so they feel different. And if you think about the human body, the clitoris is really miraculous. It is the only organ in the human body, in men or women, that is dedicated solely to pleasure. It has absolutely no other function. The penis has to do a lot of other things, but the clitoris is only devoted to pleasure. Okay. Unfortunately, there aren't any good medicines to manage primary sexual dysfunction in women. So there are a couple of FDA-approved meds to treat hyposexual desire disorder, that is the loss of sex drive or libido in women. But they tend to be, they have a lot of drug interactions. None of them have been tried in MS. And one of them has only been approved for premenopausal women with acquired sexual dysfunction. So whether or not the PDE5 inhibitors, like the sildenafils and tadalafils of the world will work, there hasn't been an adequate clinical trial in women yet. There was a small clinical trial, administered the drug, that was it. But that trial didn't address any other aspects of sexuality for women, like body image concerns. If you have body image issues, it doesn't matter if your clitoris is engorged or not, you're still going to be inhibited about having sex or enjoying it. Okay. The old model of the female sexual response cycle, which was described back in the 1960s by Masters and Johnson, said that first there's some sexual excitement that occurs that leads to desire, arousal, then the sexual response plateaus, and then orgasm is reached, and then there's resolution of the female sexual response. This is a linear model. And we now know that in women, we use an intimacy-based model of the female sexual response cycle, where we look at a number of factors like emotional intimacy. What kind of sexual stimuli are there? What kind do they desire that maybe they're not getting? We look at emotional and physical satisfaction and the psychological aspects of it. And we need to design clinical trials for women that look at more of these factors, and not just get the clitoris engorged. And I think that that will lead to much more positive outcomes in women. So we also have kind of done some work on helping women attain sexual pleasure even when they lose their sex drives. Now, normally, you only have sex when you have a sex drive, when you have that desire. So, but we know that the nerve tracts that are associated with sex drive or libido are somewhat different than those associated with sexual pleasure. So basically, uh, we kind of helped women kind of with behavioral reconditioning to relearn how to enjoy sexual pleasure, even when they don't have any sex drive. So we built this framework for how to cope with the loss of sex drive, and establishing a framework for good communication with the person and her partner, and help them reestablish um, sensual and sexual behavior. And we start them off with what I call a body mapping exercise. This is an exercise where I instruct the couple to get in a safe, comfortable setting and temperature, kind of remove their clothing, and begin by touching each other from the top of the head and then systematically moving down the body, and vary the pressure, speed, rhythm, and pattern. And MS changes the body sometimes, and sometimes it's important to kind of reevaluate what your body feels like when it's being touched, and note the areas of pleasure or of sensory changes. And then instruct your partner to alter um, his or her touch or their touch to maximize pleasure. Um, but I have them start by avoiding the genitals, just, touch each other. And when you're in the receiving position, it's important to be very selfish. You have to forget all about your partner's pleasure and just focus on your pleasure, and instructing your partner in how to touch you in ways that maximize your pleasure. And not even sexual pleasure at first. Avoid the genitals. That takes all the pressure off it, and kind of gives you this framework for communication that can then lead to it. By the way, and then, you take turn as being the giver. So each uh, partner takes turn as both the giver and the receiver. Most couples, when I give them this exercise and I tell them, all right, just do this for a month, but don't have sex and don't go for the genitals yet. Relearn this framework. Almost all couples come back to me and say, Dr. Foley, we cheated. So, we had sex, but that's okay. It's all right to cheat in that way. Okay, so this helps set the stage for that communication and that um, sensuality that will set the stage for enjoying touching and being touched. In terms of other treatments for women, just as there's a penis pump, that kind of causes the penis to become engorged, there's a clitoral vacuum pump that causes the clitoris and the tissue, the, the clitoral tissue to become engorged. You put a pump over the clitoral area and pump the air out, and blood will rush in, to the tissues there. There's vibrators and sexual aids. I, strongly encourage people in this day and age, you can get all sorts of sexual toys and aids through the mail in completely anonymous packages. So, it's very easy to acquire these materials today online and have them delivered to the comfort of your home. Water-soluble lubricants. I've had many women kind of tell me that, well, I can't, sex is painful. I'm not lubricating enough. So I told one woman to, okay, go home and get a water-soluble lubricant and use that. Don't use kind of Vaseline or any oil-based lubricants, because they can trap bacteria and, lead to a bladder infection, and you definitely don't want that. So just use water-soluble lubricants. So she came back to me a couple of weeks later saying, Dr. Foley, it didn't work. I said, well, tell me about it. How much did you use? And she said, well, I put some on my fingers and I kind of, rubbed my vagina with it. I said, no. You got to use gallons of the stuff. You have to use really sufficient amounts. Fill up that room, with lubricants. You really need to use very high amounts if you're not producing lubrication yourself. So other treatments for women are Kegel exercises. For example, strengthening the pelvic floor improves sensation and helps with orgasm. So we teach them Kegel exercises. Basically, that exercise, you can learn that fairly easily by stopping and starting your urine flow, when you're urinating. That's how you know you're exercising the pelvic floor muscles. But we don't want you to do it all the time when you're when you're urinating, because that can lead to retention of urine and cause a bladder infection as well. So learn it, and then just practice it, anytime during the day that, using those same kinds of muscles to flex the pelvic floor, maybe when you're stopped at a red light or something like that, anytime during the day. And as I mentioned before, we also teach that body mapping assessment to learn new approaches to touch and arousal, emphasizing intimacy and communication. There's a little preliminary exercise that yoga, in one very small study, improves sexual functioning. It has not been tried in MS, and the study was not really well done. A lot of oral herbs have been used for female sexual dysfunction, but there's limited data on safety and efficacy for female sexual dysfunction with herbs. And anytime you take herbs, please let your healthcare team know what you're taking. Some of them can interact negatively with prescribed meds. So, and there's a lack of well-designed controlled trials for herbal products for the treatment of female sexual dysfunction. Again, so we want to aggressively treat secondary problems like spasticity and pain with meds, bladder fatigue. Weakness is another symptom that frequently interferes. So we sometimes teach alternate positions on how you can have sex in a comfortable position when you have certain muscle groups that are weak. Okay. A lot of medicines are associated with sexual dysfunction. So, if this is something you're going to get a consultation for, make sure you bring your list of all the meds and herbs that you're taking, and vitamins that you're taking, so that, your healthcare team can sort that out for you and determine whether or not, you should be switched to a different med or doses changed. And certain drugs have something called a half-life. The number of hours that they kind of that half of the dose stays in your bloodstream. And so some antidepressants like fluoxetine has a very long half-life, and some have very short half-lives. So sometimes what we can advise people to do is take an antidepressant with a shorter half-life, and then sometimes, take a weekend holiday from it. And if you can tolerate being off of for a couple of days, sometimes sexual functioning comes back when you're taking an antidepressant with a short half-life. Okay. So for bladder dysfunction, we tailor symptomatic treatments around times of anticipated sexual activities. In terms of, coping with urinary leakage, the odds are your partner's not going to care in the first place. And in the second place, you can avoid fluid intake for a couple of hours. Males, you can use condoms for small amounts. And we also teach people how to cope with catheters, as I mentioned you before. And when we're working with a couple where there's a woman, we frequently will use an intimacy-based sexuality approach. Actually, we use it for men too. This is the approach I use with pretty much everybody. Intimacy is composed of both erotic behaviors and language, sensual, non-erotic behaviors, such as holding hands, and things that you do for each other just because that person is a special person in your life. And so, and sometimes men and women have different pathways to feel sexual satisfaction and emotional connectedness and intimacy. So yes, there are some gender differences in this regard. So what I want you to go away with tonight is how to talk about sex. Agree with your partner when and where it's most comfortable to talk about sex. Use books, handouts, or videos to initiate the discussion. And do not criticize or blame your partner. use kind of I feel language rather than you don't language in this conversation. And you have to remember, you have to expect that some sexual requests will be rejected. But this does not mean rejection of you as a person. It just means that that's not their cup of tea, then. Be aware that sexual feelings and preferences change, especially as MS symptoms fluctuate. Use nonverbal communication assertively. Take his or her hand and show how you like to be touched. Demonstrate for your partner. Grab their hand and have them touch you in the way that you want to be touched. And do not expect your partner to do anything unless you explicitly ask them or show them. No mind reading here. I was working with a French couple where the woman had MS. And when I told her this, she said, Dr. Foley, you are so American. I want him, of course, to read my mind. That's part of the romance. So there may be cultural differences. And she said I was being too much of a straightforward, explicit American in this thing. So, and above all else, do not expect perfection. This is a process of communicating and learning. Okay. All right. And sometimes we use couples counseling or psychotherapy for couples to improve and cope with tertiary dysfunction. So with a couple of couples, we needed to put them in anger management first. So I was doing a clinical trial of improving communication skills in couples in distressed marriages. And, I gave them diaries and they had to kind of record the incidents, and I gave them a structured communication template to follow. And this one woman came back and said, Dr. Foley, your approach sucked. I said, okay, let me see your electronic diary. What happened this week? And first, she was supposed to empathize with her husband, who loved to watch sports on Sundays all day. And while she had to kind of work around the house and manage the kids, and he would get a vacation day every week, and she infuriated her. So I said, all right, you have to empathize with him first. So she said, I know you must feel like a piece of crap sitting on the sofa all day while I'm working my ass off around the house. So I asked her, do you think that's true empathy? Do you think that that's what he really feels? And so put her in anger management. She came back, put her back in the trial 2 months later, sent her home with a diary again. And she came back with this. I know you love to watch sports on Sundays. That is empathy, it obviously does. But when you do that, it makes me angry because I have more work to do than you do. And I don't think that's fair. So if you could figure out how to help around the house more, I wouldn't be so upset with you watching sports on Sundays. And he immediately said, I can do the food shopping on Thursday nights, on my way home from work. They began really for the first time to have a communication that was actively solving their problems. Okay. There we are, hard at work in the lab, coming up with new treatments. And as I mentioned to you, we did a study that improved emotional communication, marital satisfaction, problem solving, satisfaction, and sexual satisfaction. And in a randomized clinical trial, we found that just giving people written referrals and asking them to talk to their healthcare team, about it significantly improved, sexual functioning in women, even primary sexual dysfunction, which is thought to be the most difficult to treat. So, I'm going to stop the share, and I think it's going to be time for questions. But if you take one thing away from this tonight, get educated, get materials, talk to your partner about, talk to your healthcare team. In our experience, that leads to success.
Thank you so much. That was a really good, really good. Bobby and I were texting each other, the technical person, about how wonderful you are and what great information. was great. Thank you. So now
Thank
we
you.
are ready for questions. What I did want to mention though, when you had mentioned about a booklet on, you had mentioned about going to the society for this information, that they have a booklet, but you also wrote a booklet for us. So the
Oh,
Multiple
that's right.
Sclerosis Foundation has one, and it's called Intimacy and Sexuality with Multiple Sclerosis. It's a fantastic booklet. If anybody would like that, we're happy to send it to them. I would encourage you, if you are interested, to just respond to the email that reminded you about this conference tonight, and just tell us your address, tell us your name, and make sure that we have that. We'll send it out to you as soon as we can. So yeah, it's a really good booklet, and it has your picture on it. So
Thank you, Deborah.
yeah,
I
anyway,
forgot I wrote it. So
yeah, it was a while ago.
yeah.
Okay, so let's at least give some basics for people that have not been with us before, so you can understand how to send your questions in. So you can use the Q&A button in the app, which also allows you to send your question anonymously if you choose, or you can ask your question live by raising your hand. And to do so, you just click the raise hand button, or you press *9 if you'd like to do that on the phone. I'll call on you, and then of course you'll have to unmute yourself. So let's go. We do have a couple. Oh, you know what I wanted to mention? There is a product called Reverie, and it's by Bonafide, and it's a suppository that's supposed to add moisture and help with vaginal when the vagina actually starts to deteriorate. You mentioned the word. What is that word? Atrophy. So it helps with that. The gynecologist can give you that. You can actually order that if you want. It doesn't have to be by prescription, but it's been around for probably about 4 or 5 years, and it's supposed to really help. So anyway, my gynecologist told me she tells everybody about it.
I'm glad you brought that up, Deborah, because
Yeah.
your OBGYN, your gynecologist can kind of advise you on what to do, just as Deborah's did. And
Yeah.
and so please, gynecologists, more than almost any other healthcare professional, are very comfortable talking about sex.
Yeah.
So ask your gynecologist.
Interestingly enough, my gynecologist happens to be my child, so she talks to me about things that most people wouldn't ask their gynecologist. But she tells me that she literally has to pull the information out of her patients, that she's there to answer all your questions, to give you advice, to direct you. And yet she knows that your vagina is dry because she's down there. She knows that it's atrophied because she's down there. But if she says to you, are you having difficulty or painful sex? People are reluctant to tell her that. So she's begging people to please tell me so I can help you. So I'm telling our audience, please tell your healthcare professionals, because they can do so many things for you that you can't get unless you ask them. So yeah, okay, that's number one. But let's, okay, so we have a question. How do I do it with a suprapubic catheter?
Okay, a suprapubic catheter will get irritated. So what we frequently advise women to do is fold the catheter up over their abdomen and kind of use paper tape to keep it in place, and then get in a sexual position, or have your partner touch you in a way that's not going to be vibrating that catheter. You don't want to get that it irritated. So that's basically that works.
Thank you. And we have a question about a clitoral pump. Where can you acquire a clitoral pump? And also, are there any topical treatments for women to improve orgasms?
Okay, yes and yes. You can order a clitoral pump online. Let's see, hold on a second. I'm gonna screen share again, because I just want to, I have a picture of a clitoral Oh, it's not in this slide deck. Um, I would just Google it. You know, you can find anything via Google. Uh, I can't remember off the top of my head the name of the company, but there's several companies that make them. And there's a couple of different kinds. There's a handheld kind where you have a handle and you pump the air out, by hand. And there's you can also get them that are battery driven, and there's a little electric pump that can pump the air out for you. Particularly if you have little hand strength. So, just Google it and it'll be there for you.
Yeah,
And there was another part. Was there another part to the question, or that was
there
it?
was, I think, was there any kind of topical anything that could work?
Yes, yes. And there are the same medicines that are used to uh, enhance blood flow for erectile dysfunction can be put on as a topical cream, to again enhance blood flow, in the vaginal area. So that's definitely a good question for your gynecologist, who will be able to guide you with what kinds of topicals you can use, because there are a bunch of them.
Okay, we also have another question. Is there something that patients can change in their diet to possibly enhance sexual activity?
Um, yes, excessive alcohol intake is associated, with sexual dysfunction in the general population, as well as in populations that have chronic illnesses. So, uh, basically, uh, I don't think there are particular foods by themselves that enhance sexuality. Everybody talks about oysters. Oh yes, raw oysters, makes me sexy. So, but there's really no studies that have indicated that particular foods. If you have any vitamin deficiencies, can lead to a loss of libido and difficulty with orgasm. So, make sure, you have at your annual checkup, you have a full panel kind of done, a metabolic and comprehensive panel done to make sure that metabolically, from an endocrine perspective, everything is balanced, because many other things besides MS can cause sexual dysfunction. Your endocrine system is critical for having a good sexual response. So if you have a thyroid issue or something metabolically going on, then that could interfere as well. So in terms of foods, just, not excessive alcohol intake.
And aging is,
Yes.
we take that out of the equation, but when we used to have live educational programs and people would come, we'd talk about pains and symptoms and things like that. I would stand up and say, we forget that we're aging, and with aging comes aches and pains and all these things. We want to blame everything on MS, but it's not all on MS, right?
Deborah, that's a very good point. When my wife and I were young, we used to have sports injuries. After we turned 60 and gotten well into our 60s, we started having sleeping injuries. You go to sleep, everything feels fine. You wake up, something hurts. Or sitting injuries. We don't get sports injuries anymore, but now we get sitting injuries. So,
Oh my God, too
and,
funny.
and to your point, Deborah, also, you just reminded me of a couple I treated. I gave a lecture for the community on enhancing sexuality in MS, and a couple made an appointment to see me for a consultation. They came in the office. They were both in their 60s. They'd been married almost 40 years. And they said, Dr. Foley, we realized from your lecture we have sexual dysfunction. I asked them, what makes you think you have sexual dysfunction? Well, we haven't had sex in 5 years. And I said, well, does either one of you miss it? And they said, no. We're very close. We're like best friends. And, they both had health problems. She had MS and he had a bunch of health problems, cardiac problems. And and it's not like one was missing it and the other wasn't. So I told them, you do not have sexual dysfunction. You are just fine, exactly the way you are. So I sent them out of the office happy. And it made me realize that sometimes when I'm talking about this, I can be giving a bad message, the bad message that people should be having sex. You don't have to have sex. It's a choice. Like you don't have to eat steak, or you don't have, it's just a simple, choice in a behavior. It's not necessary. So if you and are content to be without, then be content to be without. Other
Right.
things, let other things fill your life.
And we forget what it was like in our relationships at the beginning when there was no sex, and we still felt sexual and we still felt like it was intimate with the kissing and the touching and all of that stuff and the rubbing your hair. I mean, all of that stuff is still important, and we forget about that once the sex starts. So, you know,
Yeah, you're right. It's very important to maintain the central aspects of a relationship. I was working with one couple, Deborah, who had stopped having sex, and I asked them to think about what happened. And it started when they had an evening ritual, where every evening they would sit on the couch. She had MS, and he would gently rub her legs, just sitting there watching TV. And she developed sensory paresthesias in her legs so that his gentle touch now felt very scratchy and uncomfortable, and even at times painful. So being a good husband, he stopped touching her. And they didn't realize it at the time, but that sensual touching, like you just mentioned, rubbing someone's hair or, just touching your partner in a non-sexual way, that was like a gateway behavior for them to lead to a sexual exchange. And when that gateway behavior stopped, their sex life stopped. So if MS takes something away, you have to work around it and find other things like other behaviors that will be, pleasant and engaging and lead to a possible sexual encounter.
wonderful advice. Wonderful advice. Let's see, we have one more question. How do you spell the name of the suppository you recommended? So I believe it's R-E, V as in Victor, A-R-E-E, and it is by the company named Bonafide. And you can look it up. They have a tremendous amount of information on Facebook. They have an entire Facebook group with everyone raving about it and telling you how it's changed their lives. And it used to have to be by prescription. It's not any longer. And I'm the poster child for telling the entire world about it. So, and your gynecologists will all know about it because it's the newest thing to help people. So there you go. So I believe we are out of questions. And I think unless you have something else to say, I'm going to give our little message at the end. Do you have anything else?
The only thing else I have to say is I want to thank you for participating tonight. And it's kind of always enjoyable to work with Multiple Sclerosis Foundation. Thank you, Deborah, for inviting me to do this.
We love having you, Dr. Foley. So here we are. That's bringing us to the end of our time. If you've missed any part of this conference, it has been recorded and it will be available through the MS Focus Facebook page and YouTube channels. Reply to your registration email for information on how to access the recordings or sign up for our newsletters to learn more about our upcoming events. Our next teleconference will be Tuesday, January 10th, because this is our last one for 2022. And you are a bang to go out with. I love the fact that you are our last one for 2022. Let's talk about sex at the end. So,
Right.
but on January 10th, we're going to have Dr. Ben Thrower discussing generics versus biosimilars versus bioequivalence, and what does all of that mean? So it should be really interesting. That's going to be January 10th, which is Tuesday, and it's at 4:30 Eastern time. As you leave the conference today, please take a look at the survey that's going to appear on your screen. We ask that you take a moment to give us your feedback on the program and your suggestions for future topics, so we can be sure to give you things that are meaningful for you, rather than us coming up with things that we think are meaningful. We'd prefer if you take that moment just to let us know. So our sincere thanks to all of our attendees tonight, and especially to Dr. Foley. for taking the time out of your busy schedule and being here with us tonight, and not only talking about sex, but making it fun, really.
Right.
And we appreciate that. So if anybody would like to get that booklet once again, please respond to your email that we sent you reminding us, and we'll be happy to get that out in the next few days. We have a lot of them in our storage and we're happy to send it out. So good night, everybody. Have a wonderful holiday season, and we look forward to seeing you in 2023. And once again, thank you, Dr. Foley. It's been wonderful.